All right. Hey, everybody. Welcome back to the Strong and Simple podcast. This is Marissa, and I'm here with my lovely co-host, Michelle.
Hey, everybody.
And we are joined today by Dr. Katie Wadland. And I'm really excited to introduce Katie. I've known her for quite a while, going back to my Wakefield days. So just to give you a kind of quick intro, Katie is a doctor of physical therapy and board certified geriatric clinical specialist with over 14 years of experience in inpatient, outpatient, and home care rehabilitation settings. She's worked at some of the region's best hospitals and home care agencies, including Spalding Rehab Hospital, Braintree Rehab Hospital, and Beth Israel Lahey Health at Home. She has expertise working with older adults, people with neurological disorders, and other complex medical issues. She's the owner of Healthy Aging Essentials Physical Therapy and provides in-home physical therapy and wellness services for people living in Wakefield and the surrounding towns. So, Katie, welcome, and thank you so much for joining us tonight.
Yay.
Thank you for having me. I got to say, my intro sounds way better when you read it than when I read it in my head. This is good. I got to keep this.
Ooh. You're welcome. So, Katie, tell us a little bit about kind of how you got into what it is that you do.
Yeah, I mean, the long or the short of it, I guess I became a physical therapist. I really was interested early on in working with people with disabilities. I spent my years when I was like 11 to 20 something working with people with disabilities in a variety of settings. I taught swim classes. I ran summer programs, did a lot of babysitting, a lot of kind of respite care. So I knew that was what I wanted to do. And then when I got to college, I ended up taking a physiology class and a neuroscience class and really fell in love with the study of neuroscience. And from there, I kind of tried to figure out, all right, how can I work with people with disabilities, but also really, focus on the scientific part of it. I did some internships, sort of whittled it down to an allied health profession and went into PT school. And the rest is history. I guess the more recent history is I worked for outpatient neuro settings for about 5 years after I graduated. That's when I was at Spalding and Braintree Rehab, and then a small clinic in Medford. And then I ended up switching over to home health about 8 or 10 years ago at this point, and loved it. I really thought it would be a new challenge for me and something different. And I really fell in love with kind of the more medical side of things. When you work with older adults, there's a lot more medical than I was expecting. You basically become a PT and a nurse and a paramedic some days, and you're triaging all the time. So it really was fascinating to me. So I loved that part of it. I loved working with patients in their own homes. I really enjoyed getting to know people's families and sort of how they live and learning how to help them in their own environment. And then COVID came around and I was home with my kids because they got kicked out of school and sent home to learn with me. And from there, I took a leave for my family and found out that I am not meant to be a stay-at-home mom full time. So I went back to the drawing board and tried to figure out a new plan for myself. And this is what I came up with. I decided to launch my own practice. My plan was just for it to be me, to be able to treat a little bit when my kids are in classes and go from there. And I found that it's a really undermet need. There is a lack of physical therapists that do what I do. People tend to see a home health agency or they go to outpatient, but there's a lot of people who really struggle to get out and about. And those are the folks that I really specialize in working with. It's like the older adult, the person with a neurological impairment that may need some help getting around, may not drive. And that's where I kind of found my niche. And the practice has grown tremendously. And I now have 6 other therapists working with me, which is amazing. So 5 PTs and OT and myself. And we are busy, and we've been able to branch out a little bit and do community fitness as well, and a lot of community education. So it's been a wild ride. It wasn't planned, and this certainly wasn't my goal to open up my own practice, but life is funny, and here I am.
Wow.
That is so cool.
Yeah.
Wow. Having a team of 6 folks that's amazing.
Yeah. Congratulations.
It's funny. I thank you. I never even applied for a manager job. Like, it was never in my kind of personal goals was to be a manager, director, or anything. My husband always asked me, "Oh, do you want to apply for that open director role?" And I'd be like, "Not in a million years. Not for me. Not interested." But I really like teaching, and I feel like it's given me a chance to use my creative side more and teaching my clinicians. And, it's been a really nice change of pace for me to learn sort of how to manage a business from the other side of things and manage employees from the other side of things and do things the right way.
Yeah.
I've seen a lot in my days, and I feel like it's given me the chance to really create from scratch a practice that I think really is best for both the patients and the employees. And that's a really unique quality, I think, of my practice.
Yeah.
Love that. Can you tell us a little bit more about that starting from scratch with being able to build what is best for both patients and for your staff? Like, what does that look like?
Yeah, I mean, I think that, if you ask somebody what was PT like, you'll hear a lot of different things. Sometimes you'll hear I had a great therapist, but the food was terrible, or I was rushed out of the hospital and sent home really quickly. Or opposite, the PT was really distracted. They had a bunch of patients and there was an aide working with me, and I just saw them for 10 minutes and then, went on my way. There's a lot of other constraints therapists have to work under when they work for a big company or a big hospital. There's productivity constraints, there's financial considerations, so a lot of that, as much as we want to be like the best we can be all the time, there's other factors at play. And sometimes there's limitations on how often we can see a patient, how long we can see a patient, all that. There may be long wait lists. So I was able to sort of start from scratch and really decide what are my priorities. And my priorities for the patient care was one-on-one, no rush. We're with patients for a full hour usually, which gives a lot more time for education, a lot more time for some of the soft skills that I think are really critical to improving therapeutic alliance. And this is stuff we've known forever, but now there's science behind it. They're showing that some of our skills are no better than someone else's skills, but if you have better soft skills and better therapeutic alliance, patients do better, which isn't surprising. It's really when someone buys into what you're working on, they take more ownership and they do better. So the other part that I think I've been able to really focus on in improving patient care is education. The way we operate is we bill per unit. We bill 15 minutes of therapeutic exercise and 10 minutes of gait training, and you're supposed to fit everything into these little chunks of time. And typically you're busy. You're seeing a patient 30 minutes, then you're seeing another patient for 30 minutes, and then you're running to the next one. So by having, longer spots in the home, less distractions, there's time for all of that billable stuff. And there's also time for education and listening and taking the time to make sure your patient really understands what you just discussed and all that. And on the other side of things, my therapists are not overwhelmed. We see 4 or 5 people a day. Everybody makes their own schedules. That's my number one rule I tell people. I'm like, I can't promise you're going to be busy every single day. And so far, everyone's been busy every single day. So that was silly to even bring it up. But I've always said, like, if you need a day off, like, you don't need to ask me for a day off. Like, put it on your calendar. Block your day. I don't care if you're going to the beach or going to the doctor. It doesn't matter to me. We're all individuals. We're all responsible. Take responsibility for your own caseloads. Ask for help when you need it. And I'm trying to really balance off giving my therapist autonomy and giving them really good support and education. So, I mean, that's probably a long-winded answer to that question.
No, I don't think it's long-winded at all. I think you hit on so many really important points, and I can absolutely see how the environment that you created definitely benefits both the patient as well as the therapists on your team. I know, like, I've been in the physical therapy setting many, many times because I'm really good at hurting myself.
A plus
for hurting myself. But I've worked with a lot of people who have done physical therapy, and one of the things that I hear over and over again from them is they feel like it doesn't help them because insurance only allows you 10 sessions or whatever it is, and you feel like you're part of this just revolving door. It's like you're in, you walk, you squat, you sit, you leave, and maybe they'll email you some exercises to do at home. And they don't understand why they're doing those things. They don't understand how they're connected to their betterment in terms of their condition. And so they stop going. And then they never get to reap the benefits of it.
Yep.
Yeah.
And it's not, there's no magic pill. Like I love it. I have a patient's daughter asked me last week, he's really struggling to get out of the chair. What's the best exercise? I'm like, it's getting out of the chair. Like, there's not a magic solution. Like, it's literally doing the things that are difficult over and over and over again until they're stronger. And I think that, therapy historically, a lot of people expect physical therapists to fix the problem. I'm going to go in here and they're going to fix my pain. They're going to fix my walking. They're going to fix my balance. But it's not, it doesn't work that way. It's really an interactive relationship between the therapist and the patient. And if you're not teaching exactly the why, like you mentioned, there's no buy-in and there's no reason to carry over what you're learning. You should interview one of my class participants at the senior center. They're probably like, she's great, but she gives a lot of lectures. Like I'll be like, we're doing squats and here's why. So I feel like I can't stop myself. There's always this layer of like, we're doing this, but here's the why. This is why I care so much. This is why you should care so much. And this is why you'll be successful if you do.
Yeah. Yeah. I know it can be so challenging. I feel like, I think from a perspective of, people like me and Michelle who like, fitness is part of our careers. Like we love knowing the why, like we geek out on that why, but for other people, they're like, I'm sorry, what? So I could totally see that. But I think there's so much value to knowing why you're doing things, regardless of whether or not you're interested in why, Yeah.
Yeah. I think it provides a little bit of buy-in too, by understanding like if I do this exercise and I do it consistently, then this will likely be easier for me, or I can be more efficient at this, or I can be more independent at this if I keep practicing it.
Right.
So it can give a little bit of an improved why. Yeah.
And that goes into the goal setting piece too.
I think
like I sit down with each of my patients at the beginning. I'm like, why do you care about all this stuff? What's your goal? And that should be the forefront of any good clinician's plan, is really identifying like, what is the primary goal? And if you're not working towards that, like you're not going to get results for anyone, So I think it's really keeping that in mind and then progressing your plan based on, achieving near parts of that goal to the end of the goal.
Absolutely. Absolutely. I think one thing that folks tend to struggle with when it comes to physical therapy or even like rehab in general is feeling like it's not moving quickly enough, right? Or, getting frustrated with like, okay, how many more sit to stands do I have to do? Like, this is like a rudimentary movement or things like that. But, obviously it's consistency that makes the difference with these things. You have to persist. You have to continue doing those things in order to actually get stronger. Do you ever have clients that voice frustration with that? And how do you approach that, wanting to progress, but not being there yet?
Yeah, especially with the older adults. I'm going to backtrack, I think, a little bit on your question, but a lot of the goals I have for my older adults is not necessarily progression. It's prevention of getting worse. That's sometimes even more frustrating. Like, especially like if you think about bone density, here's a great example. People come in, they want to improve their bone density. Chances are, honestly, most people are not going to improve their bone density, but they are going to prevent it from getting a lot worse by doing the exercises, and they're going to prevent falls and prevent fractures. So sometimes like the null is actually the win, right? You're not improving something, but you're preventing sequelae down the road. So, you look at the different levels of prevention, the primary, secondary, tertiary prevention kind of schemas. Is that how you say that word? I never say it right. Schemas, I'll look it up later. I'll fact check myself.
I think it's schemas.
Schemas? Okay, it's pluralized, right?
I say schema.
It might be schema. It might be single.
Schematics, right?
All right, schematics. We'll deal with this one later.
It's schema.
But yeah, absolutely. And I think the solution to that is really setting stepwise goals. And it happens all the time where a patient's goal is really not necessarily reasonable. They haven't walked in 6 months. They've been in a wheelchair and they just want to walk again. And then if I actually dig in a little bit, why do you want to walk again? What does that give you? I want to be able to leave my house. Well, there's other solutions for leaving your house besides walking. Like walking gives you an awful lot, but a power wheelchair might be the right thing for you because walking may not be a reasonable goal, but you can definitely, achieve your goal of independence in a different manner. So sometimes teasing apart why the goal is so important can help figure out a better way to achieve it. And also giving educated best guesses. There's a lot of research out there on recovery times. And I see some patients that have had strokes or brain injury, and I can give them a pretty solid estimation. Like, you're going to get a lot of progress in the first 3 months, and then it's going to plateau a little bit. It's going to get frustrating, and it's going to be, a little slower for the next 6 months. But you have 2 years of window of opportunity. So it's sort of setting the stage and expectations of what's reasonable, what's lofty, and I'm all about optimism. Like, if a patient wants to work towards a goal that's lofty, I'm on board. But I'm also not going to give them false expectation of this is a realistic expectation to achieve with therapy. So it's a balancing act all the time of not shutting someone's goals and dreams down, but finding ways to help them achieve the like emotional kind of the goal, I guess.
Yeah, absolutely.
Yeah, I think that managing expectations around goal setting, as to, it's great to have that stretch goal, but also recognizing what is achievable and challenging at the same time.
Right.
And looking at like that expectation management might also be in how long it takes to reach that goal. So sure, we might be able to get you walking with a walker or with assisted technology, right? Like out of the wheelchair, but it might take you a year and a half to reach that goal. Whereas we can, reach that bigger goal of independence using other technology to get you there in a shorter amount of time while we're still working on that sort of thing.
Right. Absolutely. Yeah, totally.
Yeah.
Yeah. I really want to talk more about physical therapy for aging populations, because I think that that's something that folks overlook so often. I think, and this could be a misconception, who knows, but I think folks tend to think of it for aging populations most often in terms of grandpa fell and he broke his hip and now he needs physical therapy to rehab from it. But, just in the, 17 minutes we've been talking, you've already alluded to the fact that, physical therapy is a valuable part of injury prevention. It's a valuable part of, maintaining mobility, independence, things like that. So for folks that, say they're caring for an aging relative, or maybe they are the aging relative, what are some of the signs that physical therapy may be beneficial to that individual?
Yeah, I mean, the biggest sign is you're struggling to do what you used to do easily. That's the biggest thing, is if you were normally, I always talk about the slippery slope of aging. So if you can picture like a slide, at the very top, there's the fun status. You're young, you're active, you're working, you're having your kids, whatever you're doing. It's kind of like you're fully functional, 100%, right? All guns blaring. And then you slide down and you become from fun to functional. And your day is really structured around just getting your day-to-day things done, right? Showering, dressing, toileting, going to the grocery. Maybe you're doing like some care for grandkids, that kind of thing. So things are functional, but you're not able to really do all the fun things anymore. You may have stopped going to the club or playing golf or tennis, or these things are, you feel unbalanced, so you're avoiding these things. So then you slide down even more, right? Into the kind of pre-frail area. And then you are in the hospital a lot. You're having you're having a hard time managing your comorbidities. Most people come to me with at least one, if not 5 or 6, past medical history comorbidities, whether they're cardiac disease or neuropathy or a history of cancer or diabetes type 2, whatever it may be. And then you end up, progressing towards death. So my goal for everybody is to find out where they are in their slope and then teach them what they can achieve, right? Where can you be? The higher you are on the slope, the slower your progression down is. And the easier, the more resilient you are in able to deal with whatever life throws at you, whether that's COVID or a fall or an exacerbation of your heart condition, and it's not going to become a surprise to you at all that the factors that improve your resilience are exercise, increased physical activity, proper nutrition, stress management, good sleep, and enough support. So it always cracks me up. This stuff like isn't rocket science at all. It's like, just take care of your body. And then a lot of these other things really level off and don't become so problematic. And it's overwhelming to most people if they start from a very low level to even think about sort of moving up in that slope. So that's where I come in, and I think I'm really good at sort of guiding people to what they can do and giving them some empowering them that you have the ability to make changes, whether that, I'm not going to start someone who hasn't walked in 6 months going for a jog outside. Like, we scale things, I do a lot of functional strength training, just like you guys do, but I scale it. So today, like, I have my fitness class at the senior center, and I love watching them because these are a lot of women who thought that I was batshit nuts at the beginning. Like, I went in there and they thought I was a crazy person. I was like, all right, today we're doing like squats with thrusters and we're doing, deadlifts. And I just sort of revamped like a functional strength class to really be just like you guys would coach a 20-year-old, but modified to meet their needs and work within their body types and really addressing whatever injuries people had in the classes. I think that there's so much to aging that you can modify based on behavioral choices and activity levels. And people have no idea what the impact is. Like, when I give a lecture called The Magic Pill sometimes, and I talk about that physical activity and exercise can reduce your chance of dying prematurely by 30%. And if your doctor went in and said, here's a pill, there's no side effects, there's no copay, and you're going to reduce your chance of dying by 30%, like, who wouldn't be like, yep, I'll take the pill, So I feel like there's a lot of missing education there, that people have the ability to control the trajectory of their lives by making simple changes, sometimes not so simple changes. But, giving people back that power, I think, as they get older, that they don't just have to like wait to die. I think there's a lot more that can be done to manage chronic disease, to manage pain, to manage arthritis, to manage fall risk, all this stuff that, we associate with aging, to manage losing your independence. These are really big concerns for people, and it makes people be more withdrawn. It keeps people in their homes. It keeps people away from the community when they're scared about being seen with their cane or their walker or that sort of thing. So I think there's a lot to be said for that.
Absolutely. Absolutely. It's kind of funny. I mean, so often I hear, if there is a particularly active senior and somebody comments on how active they are, sometimes they'll jokingly respond like, well, if I stop, then I'll die. And it's like, well, you're not wrong.
Right.
Like, there actually is some truth in that.
It's very true. Yeah. And it's, there's two different components. It's physical activity and exercise, and they're different and they're separate. And I think that some people think like, I'm not an exerciser. I'm not going to go to the gym. I don't like classes. I can't do it. My knees hurt. And it's not just exercise that counts. Just moving your body in a way that feels good is beneficial. And I think that's where my job is trying to help people find ways to move their body that feel good. Like, I don't want to do therapy and have someone be like, this hurts, I don't like it, I don't want you to come back, right? I'm always trying to find ways to make people successful and to feel good. And people do. Like, I'm sure you've seen it a million times with your clients, and they think it's going to be hard work, and it is hard work, and they're sore, but they feel so much better afterwards.
Yeah, absolutely. You're totally speaking our language. Move in a way that feels good.
Exactly. Just different stages of the game,
Yeah.
Yeah. And I think that, we live in a culture where we're moving less than we have historically, right? We spend more time sitting, we spend more time in the car, commuting. We don't necessarily have the same amount of time that may have existed for some folks, 50 years ago to go on long walks or whatever. But there's also this preconceived notion of like what movement is and what exercise is that's perpetuated by the fitness industry. That makes people have this, exercise isn't for me, movement isn't for me, it's going to be so uncomfortable, I'm going to hate that it's like scary. So really trying to shift that kind of mindset for an entire population of people is a huge undertaking. And you're doing it well. So
thank you. I'll give you an example. Like, we did our class today, and I try to put a finisher in sometimes, and I did a mountain climber burpee Tabata finisher after they had done their functional strength. And of course I got like the normal groans, and I'm like, it's time for mountain climbers and burpees. And they all did it. And I just love hearing the reactions. Like, they don't think they're capable of doing this sometimes, and then they do. And while we're walking and warming down, I really said, like, I love a finisher because it's an emotional experience where you think you don't want to do anything else because you're so tired. And then your body is there for you and it can do it. And that shows you can do hard things when you are exhausted, and you can do hard things when you feel like you can't do hard things. And that itself is a lesson for anybody, I feel like, to know that, you know, you're capable of more than you think you are, and to push yourself when you're at your tiredest. That's how you learn that. And I'll do finishers in the house with people who
Absolutely.
are
It's such a
much
powerful
lower
thing.
level. Like, you don't have to do a burpee mountain climber. It can be, you know, 2 laps around the kitchen, walking as fast as you can after you do your functional strength with me in the kitchen. Like, there's so many variations with the same, you know, fitness forward approach we can use with older adults.
Yeah. It's such a powerful thing to observe in yourself too. That moment where you're like, I can't, I don't want to, and then you do. It's a really amazing thing.
Yeah.
I'm wondering if you could speak a bit to like muscle loss, bone density loss, particularly in women. I know we have a lot of women listeners. And we've done episodes talking about menopause, things like that, but I think there's not a lot of understanding and knowledge about the relationship between just gaining numbers on your age, and muscle loss, bone density loss. So can you speak a little bit to, you know, what is the typical pattern that we see in terms of people who are aging, losing that muscle, and kind of things that people can do around that, I guess?
Yeah, absolutely. You know, I think that there's changes that happen with aging no matter what you do, right? There's some natural physiological changes you cannot control.
Yeah.
You know, we have more adipose tissue and less lean muscle as we age, right? There's decreased collagen content. So collagen is responsible for the joints flexibility, for the muscle regrowth. And then you combine that with, you know, less protein intake. People tend to eat smaller amounts, less protein throughout the day. And it sort of, and then you add menopause and you add lack of estrogen, and that throws everything off. And that all combines to a, you know, a slow loss of muscle strength, and a loss especially of the power fibers. So there's 3 different kinds of muscle fibers. There's the endurance muscle fibers that are meant to like hold you up all day long, kind of keep you up nice and tall. There's the muscle strength fibers that are meant for like lifting a weight, pushing a weight. And then there's the power fibers, and those are the ones that move quickly. So those are like the jumping muscles, or moving quickly out of the way of a car, that kind of thing. So we keep the endurance muscle fibers most of the time, and then we lose the power ones the most and the strength ones secondary. That said, what they have found is that older adults can gain strength even if they don't gain muscle mass. So there's huge benefits of strength training for older adults, and especially power training, even if you're not seeing the physical changes as much as you want to necessarily. You might not see the muscle hypertrophy you're expecting from doing strength training because there is more adipose tissue, there is less lean muscle. What happens is that the muscle gets better innervated. So every muscle has a motor unit from your brain that goes from your brain down your spinal cord into your muscles. And those basically can increase how many junctions they have. So there might be 1, and then you do strength training, and there's 5. So that muscle is now a better, more efficient muscle without actually changing in size at all. So that's sort of how muscles tend to get stronger with age. We can also do the same thing for the power fibers. We can make the power fibers more strong. And that's a really important thing that's often overlooked in older adults, is working on power strengthening. People are often afraid to jump because we've been told if you jump and you have osteoporosis, you're going to break all your bones. So not completely accurate. There's been lots of studies that have shown that it is very safe. I'll get more to bone density in a minute, but it's quick movements and strong movements that really increase the power strengthening. So what I typically see in senior classes is low level, high repetition, repeated exercise, which is basically increasing endurance strength, which we already know already exists in older adults. That's fine. That's actually not that impaired. What older adults are not taught to do is the higher intensity, higher RPE, higher exertion, challenge strengthening that they need to do to really tackle those other muscle fibers that do get weaker with age. So that's the muscle mass part of it. Then you get bone density. So bone density is the highest is going to be around 30. So I hate to say it, I think we're all too late, right? I think we're all past 30. I know I'm way past 30. So, yep, hit 40.
Yep.
That was
Ship
great.
sailed.
It's out. We're
Yep.
already going the downhill slide here. So we lose about between 0.5 and 1% of bone mass per year from the age of 30 till around menopause.
Mm-hmm.
Around menopause, we lose
Mm-hmm.
between 5 and 7% more because that sudden drop in estrogen. So ideally, like I should be having this talk with 8-year-old girls, not with whoever's listening to your podcast, because that's the age where you want to start loading up your bones, doing weight bearing exercise, getting into some sort of, routine strengthening. If you don't do any weight bearing exercise, if you're not an avid active kid, by the time you hit 30, you're already at a disadvantage. Your bones are already weaker than they should be. So we want to like add as much as we can to the bone bank early on. So we start as high as we possibly can. So when age does its thing that it's going to do, we go down that slope slower. That said, we have so much we can do no matter what age you are to increase your bone mass and to prevent the sequelae. Again, my plurals are terrible. Sequelae, I'm not sure.
Oh, I love them.
I didn't take Latin. I don't know.
Excuse me. So, that's when the strength training gets really, really important. And I think that I would say at least half of the older adults I speak to on a regular basis, I say, do you exercise? Do you like to exercise? They go, yep, I walk every day. And that is not adequate exercise and resistance training enough to build muscle or to keep the bones strong. So you need to do exercise that stimulates the bones more than they're used to handling. So that's how bones re-go. So there's a concept called Wolff's Law. So if you break a bone, the way the bone heals is by laying on new bone. And the way bone grows normally, if you don't break a bone, is you feel a stimulus, whether that stimulus is like an axial loading, so there's weight bearing going through the long bones, or muscles are actually pulling on the bones when you're doing a contraction. So that stimulus tells the bone, oh, I'm not quite strong enough, time to put more bone layer on. And that's how you build bone strength. So, I get a lot of women I teach a strong bones class, an osteoporosis class. A lot of women who ask, like, if I take your class, will it improve my bone density? And well, I'd love to be like, yes, or your money back, sure, but I can't say that. What I can say is going to prevent you from losing more bone that you'd be losing if you did nothing. So it's really important to start now. It's really important to work on your posture so that forward rounding doesn't happen, because it's that forward rounding that causes so many osteoporotic compression fractures in your spinal column. And it changes your like internal viscera, like it squishes things. So when you're forward, you get more trouble breathing, you get more trouble digesting, it slows motility down. So coming up strong, even if you're not changing your bone density and keeping your posture strong, makes a huge difference in osteoporosis management. And then you add the whole fall prevention layer to it. You can have osteoporosis for 80 years. As long as you don't fall, you're in good shape, right? You might have a compression fracture from kind of spinal compression, but the big problems are when you fall and break a hip or you fall and break your wrist. So if you can improve your balance and your fall prevention, that's half the battle, and that has nothing to do with your bone density. So there's always like different sides to the picture.
Yeah. I think this was reassuring. So it's like, it's never actually too late. I mean, you can't guarantee growing new bone or, increasing bone density, but it's never too late to do something to improve that situation, which is, I think, good for folks to hear.
Yeah.
Yeah. I actually know somebody, I won't name who it is, but this person has severe bone density loss. And this is not made up. She sneezed, and in that jerking forward to sneeze, actually fractured a vertebrae.
Oh my goodness.
Yeah. Because her bone density loss was so severe. It's insane. Yeah.
And most people don't even know they have fractures. Like people come home like, I saw the doctor and I have a fracture in my spine. Like, and I didn't know it was there. And that happens all the time, where there's just these chronic fractures from the compression in the spinal column, and they go sort of undiagnosed for a long time.
Yeah. It's insane. I can't imagine like walking around with a crack in my back, literally, and not knowing it. But I mean, bodies are weird.
Yeah. You get told these things by a doctor, and then people panic and they're afraid to do anything, right? They're not told, You have osteoporosis. Here's how to move safely. It's really important to keep moving. They say, don't reach your toes, don't
Mm-hmm.
flex forward, don't do this, don't do that. They don't tell them what they can do. And that's the most important
Yep.
thing, is not being afraid to move. Like, people are always like, I was told I can't twist, you know? And I'm like, well, did you
Mm-hmm.
drive here? Did you look behind you in the car? Did you wash your hair this morning? Like, all the things that we do functionally, you have to keep your range of motion and your mobility up. And it's safe to move in functional
Yeah.
patterns. It's not safe to have someone twist you at like a stretch lab into those positions, or
Right.
carry a giant weight while you're doing it. But I want my patients and my clients to feel, again, empowered, that they can move safely in a way that's going to be beneficial. And it's a lot of empowerment education, like, sometimes hand holding, taking them through motions and be like, yep, this is okay. Yep, this is okay too. Yep, still okay.
Mm. Yeah. What you just said reminded me of something I recently learned. I know previously the conventional wisdom for, rehabbing from an injury is like, don't use it, especially when it comes to like the back, assuming it's not like a catastrophic injury. But I know now the convention is, no, you should be moving
Yep.
when you have an injury. Don't go immobile.
Right.
Is that the same for aging populations?
Yep, 100%. Even more so. So we were always told RICE, right? Rest, ice, compress, elevate. Any injury, have RICE. That was sort of disproven, and the new acronym we love is peace and love. Have you guys seen that acronym? I can't even begin to tell you what it stands for unless I look it
No,
up.
but I love it.
I know, right? It's way more positive. The gist of it is your body needs movement to heal. When you cut yourself, what happens is the blood comes down, you bleed, and then it clots and it brings in all the white blood cells and it heals up the cut. A muscle tear is no different. And when you're sore from a workout, that's muscle tears. That's all it is tiny little muscle tears, which is how we actually build muscle. Again, same thing as the bones.
Mm-hmm.
The only way your muscle knows to build more strength is it gets little tiny micro tears when you lift too much, and then it lays down more collagen fibers and more proteins and makes more muscle. So, I totally lost my train of thought. I lost my train of thought. Where was I?
Peace and love.
Peace and love. So now they're really encouraging you to move in pain-free ranges, because any movement, especially like little light muscle contractions and active range of motion, is going to increase blood flow, which is going to bring those good healing, leukocytes and white blood cells, and then it flushes out the debris. So all this stuff needs to go somewhere. So when you're swollen, it's just blood flow that gets stuck there and doesn't get flushed back out. So by doing comfortable active range of motion, mobility, muscle squeezing actions, it brings the good stuff, it gets rid of the bad stuff, and it helps you heal faster. So you add that on top of aerobic exercise and the benefits of aerobic exercise, and then you're increasing oxygen flow throughout your body. So you want oxygen. So if you're, and endorphins and pain relief. So all the things we sort of taught historically are in the garbage, because really what's most beneficial, like you said, is kind of active, gentle, comfortable movement. Yeah. You don't want to do the thing that hurts. If you sprained an ankle, I don't want you to all of a sudden start doing heavy ankle strengthening. That's not what I'm saying. But doing, ankle alphabets until it really feels better is the way to go, or something just to get motion in it and keep it active and keep it moving. And then building up slowly. That's the other part. Once things are settled, then building back up to your training, nice and slow, right? Not jumping in to where you were before you had an injury.
Yeah. Absolutely.
Yeah, it's interesting because this new protocol or recommendations is still just so not widely known. Like if you do the Google for I twisted my ankle, what to do when I twisted my ankle, it still gives you the RICE protocol, the rest, elevation, and people still automatically, oh, I hurt my back, I'm going to go put ice on it. I'm going to, and this information is still not out there as much as I feel like it should be.
Yeah. I totally agree.
No, absolutely.
I was recently given the same advice and was told, no, that was wrong advice. Can we, and I don't know if this is a thing, can you
Mhm.
put to bed the debate, ice or heat?
So
For an
this is a
injury.
classic PT
Ice
joke.
or heat?
It
Heat or ice?
depends. That's what we always say. It depends, because it does. It depends.
Of course
It
it does.
depends.
Of course.
It depends why. So ice is an anti-inflammatory, right? If you have an inflamed area, it makes sense to put ice on it. However, like we're talking about this new peace and love thing, you don't necessarily want to ice if you want the inflammation to be there. So that's sort of where that gets murky. Heat increases inflammation. So heat brings blood flow. So heat can be helpful. Aside from I'm not going to go into the science behind it because I don't have enough studies to be able to, like, here's the answer to this question. What I say is if you have a tight muscle, heat is great because the heat is going to bring in blood flow. It's going to loosen it up, and then you can stretch it out. So if you are like, I just have a tight quad and I'm dying to get it stretched, I would heat, but you can also exercise. So exercise is heat. If you take a nice brisk walk, that is producing heat in your muscle. So whether you heat or exercise, you do want to warm something up before you stretch it if you're really tight. If you have, let's talk about arthritis. If you have osteoarthritis, the last thing you want to do is to bring in more inflammation. So you don't necessarily want to put heat on an achy joint if you have arthritis. But you can put ice on. It's not going to probably do too much. If it doesn't go in that far, first of all. If you have rheumatoid arthritis, moist heat is actually the best thing to do for it. So it's really kind of like disease specific. So I can't put it to bed. It remains a mystery.
Oh, damn it.
Next time I'll come more prepared with a good solution to the problem. I do both. I mean, you can alternate ice and heat.
I really just wanted you to I really wanted you to just say heat because I just love laying on a heating pad. It's like my favorite thing in the world.
I'll give you what I tell my patients. Here's what I say, Marissa. I say, if heat feels good, heat. If ice feels good, ice. Right?
All right.
Neither one of them are going to make and break a situation. Yep. I think that if it feels good and it reduces your pain and it brings down your cortisol and it brings down your stress, half the deal. Breathing. Okay, here's the answer. Ready? You know what's better than ice and heat? Breathing.
Breathing.
Okay.
Seriously.
All right.
Because what happens with any of these injuries is that you're going to fight or flight. Like something hurts all of a sudden and you're like, crap, what do? I have to go to work tomorrow. I have to ice and heat or something to get rid of this pain, right? Your cortisol goes up. You go into fight or flight. Your body starts to freak out, and then your muscles get tighter. Like do an example for me. So say you are surprised. What happens to your body? What do? Someone jumps out at you. You breathe in, you suck in your breath, and you get tight, right? So that's your body's instinct when you get surprised or painful out of the blue, is to hold a breath and tighten up. So the opposite holds true for reducing tension and anxiety. A nice slow breath in and then a long breath out triggers the vagus nerve to tell the body everything's okay. It's time for the parasympathetic system to kick on and downregulate and chill out. And that's what allows you to relax and lets a muscle relax. So actually, I think breath probably has more science behind it at this point than ice or heat combined.
You're a really good teacher.
You are.
Thank you. See, I told you.
You're welcome.
Class members are like, yeah, they told me she'd do fitness, but all she does is teach us things.
But that education goes a long way because then they can implement things without you necessarily always having to be by their side 24/7 because you can't be by their side 24/7.
Yeah. It's funny. I had a woman in my class. She slipped on the mat when she was getting up and her back went out. That moment where you're like, it's too late. It's all tight, right? And I talked her through that same thing. We sat down. I talked her through some breath work exercises, and then I showed her how to do some gentle mobility. She could not believe it got better. She's like, I would be laying in bed for 3 days normally, waiting for it to go away. And she's like, but it was better before I left class. Wow. So just cutting the cycle of like panic and anxiety and pain and letting your body know it's okay. All a muscle spasm is your body's trying to prevent injury to your spinal cord. That's what it is. Your body's tightening up because it's trying to prevent something from injuring itself. If you can take the moment to sort of calmly breathe and literally have that conversation, like, There's nothing happening. Nothing's at risk. There's no bear. I don't need to run. Do your breathing. And then things tend to relax. And if they're relaxed, you can do that mobility work. You can do that aerobic exercise, which we just talked about is more effective than not doing anything at all and letting everything stiffen up.
Yeah. That's so awesome.
Yeah.
That's huge.
Yeah. I love that. I'm like just picturing the scenario in my head in the class.
It's just like you thought it was. I was like, wait,
I don't know why.
Problem. It's, I really like
that.
So
Oh
what
my
I've
gosh.
really gained from like switching into geriatrics and really just becoming more educated in the last couple of years about this stuff is it's so much more holistic than I ever thought. Like you just can't solve things by fixing one joint, and you cannot solve things by addressing one problem at a time. Nothing happens in a vacuum. You have to look at the big picture. You have to be open-minded about the power of, your own thoughts and your own breath and what social determinants, have an impact on your patient care. It's just, there's so much more to taking care of people than we used to think of, let's mobilize a joint. Let's get hands-on and massage something.
Yeah. Oh, I could use a massage right now though.
I was like, that sounds lovely.
That sounds really good. Awesome. Well, Katie, this was such a great conversation. I feel like I learned so much. And I'm sure Michelle has too. I don't want to speak for you, Michelle, but
I absolutely have. I've been like noting little, like so many parts of this episode of this hour. I've been like making little notes like, ooh, I want to highlight this when we, post about this. Ooh, I want to highlight this. So literally it's the entire episode. So I hope, I think, and I believe that everybody who listens to this episode is going to learn a lot and have something to take away from it. And hopefully y'all who are listening want to share this with other folks in your life, to learn about Dr. Katie and also about, how simple things you can do for yourself right here, right now to just age more independently and well.
Yeah.
So yeah.
Totally. Yeah. So do you have any upcoming like special events or anything coming up that you want our listeners to know about?
Yeah, definitely. So I guess what I should have probably said at the beginning is that we do in-home therapy. So what we do, our day jobs are all physical therapists and occupational therapists. We see patients in their homes, but we're an outpatient clinic. So you don't have to be homebound like you would to get a normal VNA to come in. So we come see you, we take insurance, we take Medicare. So we do, that's, what we do most of the time. We also specialize in Parkinson's disease. So we have, a number of us have a Power Move certification and a big LSVT certification. So we really specialize in Parkinson's disease care. That's really close to my heart. My mom has Parkinson's and she has for 18 years. And she's a great example of the power of movement and keeping yourself healthy by being active. So that's kind of what's available for us all the time. I also teach classes at the Wakefield Senior Center. I teach every Tuesday and Friday. I do a strength training functional fitness class on Tuesdays and a balance class, a strength and balance class on Fridays. We also are teaching, it's called Strong and Steady program at a number of other senior centers. We're teaching it at the Jenks Center in Winchester, the Arlington Council on Aging, and we also sometimes teach the Steinberg Center. So the Steinberg Center in Concord is a wellness center. And that's where I teach my strong bones osteoporosis class through. So that's always available. I teach that twice a week virtually, and I can send you some links. I am really excited to be training with, so the city of Melrose is launching a new campaign to get everyone involved in Melrose, whether you live there or work there, certified as a mental health first aid certificate. So I'm going to be going to train myself. I know, I'm really excited. So next week I'm going to the instructor training to be a mental health first aid instructor. So I'll be teaching these courses for the city of Melrose, and they just sent out the brochure. They're free for anyone who lives or works in Melrose to come in. There's a couple trainings in October and November. There's like the adult version and there's the adolescent child version. And it's a really awesome program. Like, we didn't talk too much about mental health because it's not normally in my wheelhouse. However, especially older adults are facing so many changes that they have a lot of anxiety and depression. So we see it all the time in our clinic, and we talk about,
Absolutely.
we're always fielding questions about mental health and sort of dealing with things on the fly. So the goal, so myself and Tammy, one of my therapists, are being trained not only to provide a service for the community, but also to be able to better serve our patients. We want to be able to have the tools to identify when someone's having a mental health struggle, not only to be able to support them, but also get them to the right people for more professional help. So that's coming up. What else is coming up? I think that's all I can think of right now. Going to Nashville in a couple of weeks. That's coming up. I'm pretty
That's
excited
awesome.
about
That's
that.
a lot.
Yeah, yeah.
That's exciting. Are we invited?
It's my getaway, my birthday getaway. So I'm pretty looking forward to this.
Woo!
Nice. Well, happy early birthday. That sounds like
Thank
a
you.
great way to spend it.
Well, thank you for
Awesome.
having me. This has been so
So
fun.
if folks want to find Oh yeah, absolutely. This has been such a great conversation. We'll make sure to link all of those things. If you want to send us over those links, we'll put them
Sure.
in the show notes. And then we can also link to your website and your social media profiles there as well.
Awesome.
So everybody make sure you go check Katie out and connect with her on social media, visit her website, and, take up all these courses and activities that she has to offer. So wealth of information.
Yes.
Thank you,
Thanks,
ladies.
Katie.
Thanks.